Good afternoon, folks. This is Victor Gravio here at ABH. I want to welcome you all to our webinar today on the MassHealth Systems Transformation and specifically the impact on SUD providers. This is the third in a series of webinars we've done related to the MassHealth Systems Transformation. We're really happy you've been able to join us today. I just want to, before we get started, I want to acknowledge a few people that are in the room here today. With me, Connie Peters, our Vice President for Addiction, is here, Rosemary Santini, and then you'll be here momentarily from Megan Thompson and Lydia Conley. I want to thank all the staff, especially Megan and Lydia, for their work in putting this together, and Connie's input as well. We think we have a very good program for you today, which will hopefully answer many of the questions that you may have, and if not, I know there's points during the webinar where you'll be able to enter questions, and Lydia will try to address them. So with that, I'm going to turn it over to Megan, who's going to walk you all through the logistical information about the call and the webinar, and then we'll go from there. Megan.
All right, great. Thank you, Vic. Hello, everyone. So just a few housekeeping items before we get started. On your GoToWebinar attendee control panel, you'll see an audio tab. On the audio tab, you can select to listen in either computer audio or phone call mode. We strongly recommend that you dial in through the phone call, as on past webinars this has been the best option for hearing us clearly. You'll also see on the control panel a tab for questions. You'll be on mute for the duration of the presentation. So if you do have questions at any time, you can submit these on the questions pane through text. As Vic mentioned, we'll have a few times throughout the presentation scheduled to take questions, but feel free to submit them at any time. If you have any technical difficulties with the actual GoToWebinar platform, please call 877-582-7011, and GoToWebinar staff can help you immediately. Please note that we are recording today's presentation, and we will be sending that out once it's available after the webinar. And lastly, on the control panel, you'll also see a handouts pane. In the handouts, we've included a few different resources for you to download, including an ABH resource guide to MassHealth Systems Transformation, which Lydia has put together, and it summarizes all of the available resources that are out there. Also a flyer for provider training events that are going on around the state, a behavioral health provider fact sheet, and also the slides for today's presentation. Now, without further ado, I'm going to turn it over to Lydia.
Great, thank you, Megan. So we're going to talk about today, we're going to talk about MassHealth Systems Transformation with a particular focus on its impact on SUD providers. The presentation is going to give a condensed overview of MassHealth payment and care delivery innovations, which has also been known as MassHealth Innovations or Systems Transformation or Section 1115 waiver implementation. So this will take a while, and those of you who sat through our second webinar, there will be some repetition, but we found from the questions that we're continuing to get from members that we believe will be helpful to go into detail on some of that. We will very briefly recap MassHealth communications to members about new plan options, as well as MassHealth communications to providers about new plan options. And if you want additional detail about that, that's available on our second webinar, which is available on our website. And then we'll go into some detail about the expansion of MassHealth SUD benefits. Today's presentation is not going to address delivery system reform incentive payments statewide investments, and it's not going to talk about operational considerations such as continuity of care planning, service authorizations, claims payments, etc. MassHealth has done their ongoing operations webinars where they cover that in some detail, and there's information about how to access that as well. And then just as a note, MassHealth, ABH is going to continue to refer to PCDI as MassHealth Systems Transformation. So the topics we're going to cover today are MassHealth Systems Transformation goals and drivers, the approach and pathways, the different plan types and options that are going to become available in just a few weeks on March 1st, specifically accountable care organizations, and we're going to talk in some detail about primary care exclusivity, managed care organizations, or MCOs, the Primary Care Clinician Plan. Then we're going to get into how all of this works together in terms of networks and relationships. Then again, we're going to recap MassHealth member and provider education, and then we'll move on to the SUD expansion, with specific focus on the phased incorporation of ASAM 3.1 level of care into managed care, and then some other planned enhancements. And then we will briefly recap the timeline for all of these transformation efforts. So MassHealth Systems Transformation, the drivers and goals. So the first bullet up there on the presentation is ensuring the financial sustainability of MassHealth. So if you look at the right-hand side of the slide, there's a fairly dated MassHealth slide, but the point of that graph is to show that MassHealth spending is growing at an unsustainable trajectory. So over the past couple of years, MassHealth has undertaken some program integrity and some other initiatives to control MassHealth spending, but it's gotten to the point where really we need to do something differently, or there are concerns about the viability of the program. And the current administration has been very clear that if we can't do something to bend the cost curve, so not necessarily reduce costs, but to control growth, that we'll be talking about benefit reductions, we'll be talking about provider payment reductions, and eligibility reductions. That said, the Baker administration is taking this as an opportunity to improve population health and care coordination through payment reform and value-based payment models, and that is the Accountable Care Organization initiative that we'll talk about, to improve the integration of physical and behavioral health care, and that implicates what are called community partners, and we'll briefly talk about those, as well as scale innovative approaches to populations receiving long-term services and supports. And what that means is that MassHealth over time is going to be folding long-term services and supports, which are things like home health and visiting nursing, into a managed care environment. And which is a lovely segue to MassHealth Systems Transformation Managed Care. So the landscape for most of MassHealth Systems Transformation really focuses on managed care. So in terms of level setting, this is today's MassHealth managed care landscape. And so for those of you that are working with MassHealth working closely with MassHealth, this should look probably pretty familiar to you. So on the far left, today we have the Primary Care Clinician Plan with about 400,000 members, and behavioral health benefits are accessed through the Massachusetts Behavioral Health Partnership, MBHP. And then we today have 6 managed care organizations. 5 of those managed care organizations utilize a managed behavioral health organization, such as Simpatico, MBHP, or Beacon Health Options, and 1, Tufts Health Together, which is Network Health, manages its behavioral health internally. This is Lydia. We had a little phone glitch. Are people still able to hear? All right, Megan is doing a quick survey of you to figure out if you can hear. Okay, great, we're getting some feedback you're able to hear. Okay, so of the 6, so we have 6 managed care organizations, and today's requirement is that each managed care organization operate in 1 or more of 5 MassHealth regions, which are relatively large geographies. This is going to change under the ACO model. There are implications for care relationships, particularly between primary care clinicians and MassHealth members. We won't get into a lot of detail on that. If you want more information on that, our second webinar, which is again available on our website, has more detail about that. So the approach to MassHealth Systems Transformation that the Baker administration is taking. So the current state, and this is certainly not limited to Medicaid, really rewards volume. It's built to address emergency or short-term medical events. It's really difficult for members and enrollees to navigate the system. A person might have multiple doctors or clinicians treating them for the same condition. The clinicians may not be aware of one another or talking to one another. There is really limited to no transparency into quality and efficiency of care, and patient information is often stored all over the place. It could be siloed in electronic medical records that don't talk to each other, or it might even be in paper still. So MassHealth is hoping to move to a sustainable model, one that's going to reward outcomes and value, where a MassHealth member's health is managed seamlessly across providers and over time, so not on a visit-by-visit basis, not episodically, where providers are working together as a team to ensure the coordination of the right services for the MassHealth member at the time that they need them, get to a place where there's easier to understand quality and cost data that's available to both providers and to MassHealth members themselves, and to make appropriate use of electronic health information that will be available across care teams and with MassHealth members themselves. So one of the hallmarks of MassHealth Systems Transformation are accountable care organizations, or ACOs. So MassHealth has secured some time-limited federal investment dollars. They're called district dollars. It's $1.1 billion over 5 years. So at the end of 5 years, those funds evaporate. They're really bridge dollars to help a system get from place A to place B. Accountable care organizations are going to have responsibility for total cost of care for managed care spending. So what that means is spending on both physical and behavioral health, including pharmacy, with long-term services and support spending phased in over time, as well as being held accountable for performance on quality measures. There will be an emphasis on primary care. ACOs are responsible for team-based care management, for coordinating care, for managing care transitions for individuals transitioning in and out of the community, for conducting comprehensive assessments for select populations, and for developing person-centered care plans where appropriate. They will also have access to dedicated flexible services funding to help address social determinants of health. We understand that these funds probably won't be available at this point until 2019. The idea behind this is actually really relatively cool. If approved by CMS, the ACO would be able to access funding for certain segments of their population for things like one-time rental arrearages or one-time utility arrearages, or the example MassHealth often uses is, if you have a child that has asthma and an air conditioner would help mitigate the asthma, you can use those funds to buy the family an air conditioner. So those will become available at some point in the near future. Another hallmark of systems transformation is community partners. So community partners are community-based entities, all of whom are ABH members, or at least have constituents that are ABH members, that will help MassHealth members with high behavioral health or complex long-term services and supports needs navigate care. The community partners together, both types, are slated for about $547 million in the time-limited federal investment. Accountable care organizations and managed care organizations are required to partner with their area community partners and vice versa. The idea behind community partners is to leverage the expertise and capabilities of existing community-based organizations that have long histories serving populations with behavioral health and or long-term services and supports needs. Also, one of the policy ideas here is that it will break down existing silos, it will help deliver better integrated care, and help address social determinants of health. Behavioral health community partners and long-term services and supports community partners are a little bit different in structure. The behavioral health community partners are going to deliver health home type supports, and the specific services they'll be delivering, it is essentially a care coordination service, will be outreach and active engagement. They'll have to do comprehensive assessment and person-centered treatment planning for individuals, help manage care transitions in and out of the community and between levels of care, health and wellness coaching, connection to community, social, and flexible services. They will do care coordination and care management and medication reconciliation for people transitioning out into the community.
Okay, and now we're going to take up to 5 minutes to take any questions that you may have so far for the presentation. We'll give it a couple minutes to see how many questions come in, but it looks like we do have one.
So I'm going to read the question. The font is very tiny, and then I will repeat it. It says, effective March 1st, we will need to bill MBHP for those clients that are eligible and are in an RRS program. Currently, when we bill through EIM to DPH, we offset the billing with client contributions and food stamp income. What will be the expectation and or process for when we bill MBHP? So our understanding is that you will deduct those offsets from your BSAS billing, and we will get to that later in the program. Yes, the BSAS billing for room and board.
Okay, and we'll give it about 30 more seconds to see if any other questions come in. As a reminder, you can submit questions through clicking the questions tab of the control panel and typing in your question there.
The question is, is any of the money that is available to help agencies upgrade and change medical records? So there is funding available to the community partners that they can use for infrastructure investments like that. I'm not aware of any funding that's going to be available to providers that are not community partners. And then, so the next question is, district funding is given to providers who participate in the ACO. Any other reasons that this funding might be given? So there are district dollars available to accountable care organizations. There are district dollars available to community partners. There's been some district dollars available to CFAs. And then there is a relatively small bucket of funding. It's about $115 million for statewide investments that will fund things that will include things like loan forgiveness for licensed staff. There will be training programs for peers, recovery coaches. There's going to be a host of workforce development initiatives related to that. Those applications will be coming out in March. We're not really going to get into that today, but in many instances, you do not necessarily need to be a community partner to be eligible for those dollars. The next question, BHCP, are they actually providing the services or coordinating them and referring to providers? So the BHCP service is a care coordination service, so it's not a direct service. The BHCP may actually also be delivering the service, but they might be coordinating services with other community providers, so not necessarily themselves. The idea is not to disrupt existing care and treating relationships. It's going to depend upon the needs of the individual that's part of the BHCP program.
Okay, and that looks like that's all the questions we have so far. We will be taking time throughout the rest of the presentation to take more questions, so continue to submit them as you have them.
So moving on, accountable care organizations and a focus on primary care. And so this will be very important because there are literally hundreds of thousands of MassHealth members that will be moving into different health plans next month as a result of this. So a MassHealth member whose primary care clinician has joined a MassHealth ACO is going to follow that primary care clinician into the ACO. And by primary care clinician, we mean an entity level, and we have some slides on that in a minute. And then just a note, the MassHealth member has to live in the ACO service area in order to follow their PCC into the PCC's accountable care organization. So in some limited instances, there may be care disruptions because the MassHealth member doesn't live in the service area where they're, for the ACO that their doc has gone to, and that individual is going to have to find a new primary care doc. So primary care exclusivity. So MassHealth is envisioning a primary care-driven, person-focused care experience for members, particularly for accountable care organization enrollees. And so there's this concept called primary care exclusivity. So what this means is that each ACO's primary care clinicians, or PCCs, participate exclusively with that ACO. They cannot serve MassHealth members who belong to another ACO, to an MCO, or the PCC plan as primary care clinicians. So this is very different than today's landscape, where if you're a primary care doc, you can serve members who are in any of the 6 managed care organizations and the PCC plan. If you're a primary care doc that chooses to affiliate with an ACO, you are only going to be seeing those ACO members as a primary care doc. So what this means is the MassHealth member must join the ACO to receive primary care services from that provider. This also means that a member that has or chooses a primary care clinician who's in an ACO will be assigned to that ACO. So it's this concept that the MassHealth member is going to passively follow their primary care clinician. Primary care providers can still provide specialty services to members outside of their ACO, but can't have them assigned to their primary care panels. So this might work out in a situation where you have a primary care clinician, and again, this is the entity level. They're a primary care clinician, they've joined an ACO, but the doctor's practice also happens to offer psychiatry. That doctor could offer psychiatry to all MassHealth managed care members, but in terms of primary care, they can only serve that ACO's members. So again, this primary care exclusivity is enforced at the practice or entity level. So it's not the individual, it's the group practice or the CHC level. Primary care exclusivity applies only with respect to MassHealth managed care eligible members, and in MassHealth parlance, that means managed care mandatory. So a PCC and an ACO can continue to provide primary care to MassHealth fee-for-service members, including those who are dually eligible. to One Care members, to Senior Care Option members, to Medicare beneficiaries and commercial patients, et cetera. There is no specialist exclusivity, so we get a lot of questions on this still. So the exclusivity requirement doesn't apply to specialties like behavioral health. So if you're a behavioral health provider, you do not need to affiliate with one particular accountable care organization. You can align yourself with as many as makes sense for you. So you can contract to be in all of the ACO, MCO, and PCC plan networks, just like today. So who or what is a primary care provider? So MassHealth members are assigned to ACOs at the primary care clinician level. Primary care clinician, again, refers to an entity or a collection of primary care providers, such as a hospital, a health center, a group practice. The primary care provider, that's the individual. So that's the doctor, the nurse practitioner, or physician assistant who provides routine care for the member. So the PCP is responsible for all the routine and preventive health care for the members and makes referrals as needed. Where it gets a little bit tricky is you can have an individual primary care provider, so the person can be part of a primary care clinician, so the entity, so like a group practice, along with a bunch of other individuals, some primary care providers. Or in some instances, you might have the primary care provider, the individual, who may also be the primary care clinician if they're operating a standalone or a solo practice. And then just to note, although MassHealth members are being assigned at the PCC level, that entity level, MassHealth member communications are using the term PCP to refer to the entity, really to the PCC for simplicity. But then there's an exception for PCC plan specific materials. PCP isn't really a concept to the primary care clinician plan, so they're still using PCC for a term. So accountable care organizations, there are 3 models that MassHealth has decided to contract with. So there's the Accountable Care Partnership Plan, formerly called a Model A. This is where a single ACO is partnered with a single MCO. It's at the highest level of financial risk because there's a managed care organization involved. All enrolled members receive primary care from that ACO's primary care clinicians. These types of ACOs can serve a smaller geography than a MassHealth region. So in some instances, docs that are joining the Accountable Care Partnership plans, there may be some care disruptions for individuals because they don't live in the service area of some of the more compact ACOs. But other than that, members can see any other providers in the plan's network. So for example, behavioral health providers. So in that sense, it functions much like an MCO. So you just, if you're a behavioral health provider and then you're in the MCO's network that's partnered with that ACO, you are going to be able to see that, the members of that Accountable Care Partnership Plan. Then there's a primary care ACO, formerly called the Model B. This is an accountable care organization that's contracting directly with MassHealth. There's no managed care organization involved. They have sort of a different financial risk structure. So they're measured on savings or losses based on total cost of care, and they're also held accountable for quality measures. So all enrolled members will receive primary care from that ACO's primary care clinicians. That type of ACO might have referral circles, which gives MassHealth members direct access to specialists without a PCC referral, so almost like a preferred provider arrangement. This is not applicable to behavioral health services, but we wanted to call that to your attention because it shows up in marketing materials. But then aside from their primary care clinician, members can see any provider in the MassHealth Behavioral Health Network, which is MBHP, or the PCC Plan network for other specialties. Then there is so there's 3 of those entities, 3 primary care ACOs. Then there is one MCO-administered ACO. This is formerly called a Model C. This is an ACO that's contracting with 1 or more MCOs, and in year 1, this entity has to contract with 2 of them. Their arrangement is a little bit different. The accountability is to the MCO, but MassHealth has to sign off on it. Members in that plan, they enroll in the MCO and then either choose or get attributed to that ACO based on who their PCC is. But then otherwise, members can see any other provider, such as a behavioral health provider, in their MCO's network, just like today. It functions just like the MCO networks, which is a good segue to managed care organizations. So MCOs are also part of MassHealth Systems Transformation. They do have an important role in ACO implementation. So they're going to be the insurer. They're going to pay the claims and work with their partner accountable care partnership plans and with the MCO-administered ACO to improve care delivery and support care integration. They're going to support their ACO partners in building provider capacity, including population health management analytics. MCOs are also going to continue as a standalone option on a smaller scale. So there's going to be fewer plans and fewer MassHealth members in them. So as of March 1st, 2018, so just a few weeks away, there's going to be 2 standalone MCOs continuing. And they are BMC HealthNet, so they are statewide, and they use Beacon Health Options as their managed behavioral health organization, as they have right now and they will in March, and Tufts Health together. So they're in all MassHealth managed care regions except for the South, and they manage their behavioral health internally. So all other managed care organizations are sunsetting as standalone MassHealth MCO options as of March 1st. So what this means in practice is Celticare, Neighborhood Health Plan, Fallon Community Health Plan, and Health New England are going to sunset as standalone MCO options. So you'll no longer be able to enroll in just Health New England. However, Neighborhood Health Plan, Fallon, and Health New England are going to continue with ACO partners. So they're going to partner with accountable care partnership plans, so they will continue in some form. Celticare is going to be exiting the Massachusetts market completely. And then the Primary Care Clinician Plan, which exists today, will continue as a plan option for MassHealth members. The Massachusetts Behavioral Health Partnership will continue to be the behavioral health benefit manager for PCC Plan members. And we did want to flag some likely upcoming changes for the PCC plan. We're likely going to see significantly reduced plan membership due to migration of members to more managed options like ACOs. The Baker administration has proposed differential copays. So there'll be potentially higher copays for individuals who stay in the PCC plan versus those who migrate to ACOs and MCOs, and potentially tighter physician and pharmacy networks.
Okay, and we're going to take another couple of minutes or so to take any questions you may have so far. Okay, so the first question I'm reading is, if we are a standalone clinic and not considered by Medicaid as a CBO, we will still be able to see patients for substance abuse and mental health services and get reimbursed directly from the MCO, or will the ACO be controlling the reimbursement? So I think it will be clear. We actually have some slides that will hopefully make this clearer rather than me trying to answer that question as it's written. But if I don't answer it, if you could please ask that again. And then the next question is, so the room and board is to be billed to BSAS DPH, and any services outside of that are to be billed to MBHP. Yes, that's our understanding. Then the next question is, do we have to get contracts with plans that are new? So I will address that when we get to the slides about the different plans. Okay, so we're getting a lot of questions about contracting, so let's get through a few more slides and we'll attempt to address the contracting questions. Yeah, okay. All right, so we're going to just move along, bearing in mind there are several questions about contracting and billing relative to networks. So we're just going to briefly talk about plan choice and assignment relative to service areas and residents. This has caused also a lot of confusion, so we'll address this on this slide and the next one. So plan options that are available to MassHealth members, it really depends on where the member resides, and that the residence is based on what MassHealth has in their own records. But generally, so for the Primary Care Clinician Plan, that's a statewide plan, and members are not automatically assigned to a PCC more than 25 miles away from their home address. But at this time, they're able to choose one that's more than 25 miles away. MassHealth has indicated that may change in the future, but for right now, that's the case. For primary care ACO, so this is the type, it's the Model B, so there's an ACO contracting directly with MassHealth, and there's no managed care organization involved. These are also, there's 3 of them, they're available statewide. And again, similarly, the MassHealth member is not going to be automatically assigned to a PCC more than 25 miles away from their home address. But they may have the option to see one. For accountable care partnership plans, so this is the Model A, so there's an integrated ACO and MCO. The MassHealth member has to live in that ACO service area. So this is similar to how MCOs function today, but the service areas may be significantly smaller than a MassHealth region.
And we went into this in some detail in our last webinar, so if you have questions about this, you might want to go back and look at that. For MCOs and the MCO-administered ACO, so there's one, it's Leahy Clinical Performance Network. The MassHealth member has to live in a region that the MCO covers, the individual's MCO covers, just like today, which really shouldn't be a problem for members of that plan because it's Tufts and it's BMC HealthNet, and they're both in that region. MassHealth has estimated that each member is going to have at least 3 plan options from which to choose, and ABH staff, when we've been playing around with the MassHealth website around that, it seems like in every zip code that we've looked up, there's at least 7 options for MassHealth members. So there's plenty of choice. So relative to plan options and behavioral health networks, again, this has been coming up a lot. So specialty networks like behavioral health have no MassHealth mandated geographic restrictions. So the ACOs, the MCOs, and the managed behavioral health organizations can continue to offer statewide networks, and we have every indication from those organizations that they intend to continue to do so, at least for right now. So as with the MCOs and the PCC plan today, behavioral health providers are going to be able to serve MassHealth ACO, MCO, and PCC plan members from around the state. So you're not limited by geography. We know many of you offer services that attract people from around the state. There's no reason why you can't continue to do that, provided you're contracted with these plans. Behavioral health providers are not restricted to one ACO, so again, you don't have to affiliate with one particular accountable care organization. Behavioral health providers can contract to be in-network for all ACOs, MCOs, and their managed behavioral health organizations and the PCC plan through MBHP.
All right, so feel free to submit any questions. We are getting a few coming in, so we're just going to take a moment for Lydia to look over the questions and see if we should answer them now, if they're going to be addressed further in the presentation. Yep, so the questions that I'm seeing so far are questions that we're going to handle. They're really more contracting type questions. So we have some slides where we'll get into who you need to contract with. There is one question about, will the way you bill MBHP change? And I'm not sure I understand that question enough. So is that relative to the RRS billing or something else? So I don't have enough detail on that question to answer, but the rest relate to contracting, which we will get to. Okay. All right, so we're going to move on, and we will hopefully answer your contracting questions. So the systems transformation, the future of MassHealth managed care, and the future is basically almost here, just a few weeks away. So in terms of how behavioral health benefits are going to be accessed as of March 1st, if you're a behavioral health provider, you really only need to be contracting with 3 different entities. So on the far left of the slide, we have Beacon Health options. So if you want to serve the members of any of the 10 plans listed under Beacon Health options, you need a contract with Beacon. So our understanding is Beacon sent out contract amendments around Christmas time that made their contracts sort of more generic, and so that basically they covered all Medicaid products. So assuming you accepted that contract amendment, it came by a deemer letter, you should be in network for all of those 10 plans if you are a Beacon provider. Moving to the middle, there's MBHP. If you want to serve the members of those 5 plans, you need to have a contract with MBHP. And then moving to the far right, Tufts Health Together, if you want to see the members of any of those 6 plans that are listed there, you need to have a contract with Tufts. And so our understanding from speaking with Tufts is they had recontracted their behavioral health network about a year ago to do something similar to what Beacon just did. So their contract, from what we understand, says you are in network for Medicaid or for MassHealth products. So you are already in network for all 6 of their plans if you're a Tufts provider, provided your contract doesn't specify something otherwise. So generally, it's very confusing. We'll look at some other slides, and you'll see there's sort of a multiplicity of plans. But from the behavioral health perspective, in some ways, it's more streamlined. You're really dealing with 3 entities if you want to serve the entirety of the MassHealth managed care membership. So just as a refresher, this is a version of the slide we saw earlier. So these are the plans that are available today through the end of this month. So we have the PCC plan,
BH benefits access through MBHP, and then we have the 6 managed care organizations, 5 of whom use managed behavioral health organizations, 1 that doesn't. And then just as a note, MassHealth stopped new enrollments to plans that are sunsetting, so people who come on now, new MassHealth members, can only enroll in BMC, HealthNet, Tufts, or the PCC plan. So that's what's available through the end of the month. Starting March 1st, these are going to be the options available to MassHealth managed care members. So we'll take a look at this slide, and then we're going to zoom in under the orange bar for the ACOs. So under the orange bar, so these are members attributed to an ACO, and so we'll find out shortly after March 1st, and MassHealth estimates anywhere between 800 and 900,000 MassHealth members are going to be under that orange bar as of March 1st. So there are 13 accountable care partnership plans, the former Model A. So you have an integrated ACO and MCO. And they all manage their behavioral health in different ways. So 4 of those accountable care partnership plans have partnered with Tufts Health Together, which manages its behavioral health internally. 8 of them have partnered with managed care organizations that use Beacon to manage their behavioral health benefit. So they might be partnered with NHP, Fallon, or BMC, but all of those entities use Beacon. And then there's 1, the Be Healthy Partnership out in the Springfield area. They partner with an MCO, HNE, that uses MBHP. So for the accountable care partnership plans, there's sort of 3 ways of dealing with behavioral health. Moving to the center, there's the primary care ACOs. So these are the ACOs that there's no managed care organization involved. It's a direct contract with MassHealth. The behavioral health benefit for members of those plans is accessed through MBHP. It's almost like an overlay on the PCC plan. And then on the sort of the middle of the slide, the sole MCO-administered ACOs, this is the Leahy Clinical Performance Network. The members who are affiliated or who become enrolled with the Leahy ACO are going to access their behavioral health benefit through their MCO. So it's really going to depend which plan they get enrolled with. So if they're a Leahy member and they're enrolled in Tufts, they'll access their behavioral health directly from Tufts. If they're a Leahy member that's also a BMC HealthNet member, they're going to access it through Beacon Health Options. So that's the ACO landscape. Then on the far right side of the slide, we have the MassHealth members that aren't attributed to an ACO. So under the gray bar, we have the 2 managed care organizations that are remaining. So there's Tufts Health Together, managing its behavioral health internally, and BMC HealthNet, which will continue to use Beacon Health Options. And then you have the PCC plan. And the behavioral health benefits for PCC plan members are accessed through MBHP just as they are today. And then just sort of just for a sense of the size of the memberships. So these are just estimates. They come from MassHealth, but MassHealth recently estimated anywhere from about 440,000 to 530,000 people are going to be in those accountable care partnership plans. Anywhere from 300,000 to 360,000 are going to be in the primary care ACOs, the 3 of those entities. And then the combined membership of the MCOs and the PCC plan is going to be anywhere from 200 to 300,000. And so the MCO-administered ACO, the Leahy members, are reflected in that number on the right. So that's why they're not called out separately. So now we're going to zoom in just a little bit so you can see who the plans are. So these are members attributed to an ACO. And so under accountable care partnership plans, the Model A, so this is the far left of the slide. So these are the integrated ACO MCOs. So we've grouped them together by their MCO partners. And then we've further color-coded them so you can see who the BH benefit manager is. And we do realize this is very confusing. So the first 4, accountable care partnership plans 1 through 4, these are ACOs that have partnered with BMC HealthNet. And you can see they cover a variety of service areas. They're shaded in blue because they use Beacon Health Options to manage their behavioral health. The next 3, so 5 through 7, are ACOs that have partnered with Fallon. Fallon is also shaded in blue because they use Beacon to manage their behavioral health benefit. Then the 8th, My Care Family, that's the ACO, the sole ACO that is partnered with NHP. That's a relatively compact ACO. They're also shaded in blue because they also use Beacon Health Options to manage their behavioral health benefit. Then number 9 is the Be Healthy Partnership. So this is the partnership between HNE and Bay State Health. HNE is shaded in orange because they use MBHP to administer their behavioral health benefit. And then finally, the plans 10 through 13 are the 4 ACOs that have partnered with Tufts Health Together. So these are relatively larger ACOs, and they'll be using Tufts. Tufts is shaded in white. They manage their behavioral health internally. Then moving to the center, we have the primary care ACOs, the former Model Bs. So again, there's no MCO involved in those plans. These ACOs are contracting directly with MassHealth. There are 3 of them. There's Community Care Cooperative, they're statewide. There's Partners Healthcare Choice, also statewide. And there's Steward Health Choice, also statewide. The members of those plans are going to access their behavioral health through MBHP. And then finally, on the far right, there's the MCO-administered ACO. So this is Leahy Clinical Performance Network. Members of that ACO are going to access their behavioral health. It's going to be driven by who their managed care organization is. So you might be a Leahy member that is also a BMC HealthNet member, so you're going to access your behavioral health through Beacon. You might be a Leahy member that's also a Tufts member, and so you're going to access your behavioral health through Tufts. So then this slide is just another way to display the same plan. So the accountable care partnership plans are just displayed all together alphabetically, similar for the primary care ACOs and so forth. And then this is just taking you back to the slide that we started from the beginning. So yes, this is very complicated, but at the end of the day, as a provider, you need to have contracts with only 3 organizations. So Beacon Health Options, if you're contracted with them, always, of course, checking the terms of your own contract, but you should be good to serve the members of those 10 plans listed beneath them. MBHP, similarly. They are affiliated with 5 plans. Of course, check your contract, but if you're contracted with them, you should be able to serve the members of their plans. And then Tufts Health Together, similarly, there's 6 plans that Tufts administers the behavioral health benefit for. If you have a contract with Tufts, you should be in network for the 6 plans listed there.
Okay, so hopefully that section answered a lot of your contracting questions, but if not, please feel free to send any more in now. Well, we know that was a lot of information, so we'll give you a couple of minutes to let it sink in and send in your questions.
So the first question we're getting is, this is another one I'm not sure I understand. At the MassHealth meeting, they advised that we would need to bill MBHP via MassHealth now. And the person asking is looking to verify this. I'm not sure I understand how that scenario would work. I also wanted to know if the payer ID will change for this. The early indications we've gotten is that the payer ID is not going to change, but we haven't received a definitive answer. I'm just going to scroll back up to previous questions.
All right, we're going to give it a few more seconds to see if any other questions come in. If any of you had submitted previous questions that were not addressed, please resubmit them so that we can make sure that we can explain it more clearly for you. All right, we're going to go ahead and continue on then.
So networks and relationships, and hopefully some of this will help bring this together for you some more. So how does all of this fit together? So we're going to look at the systems transformation from the primary care provider perspective, from the specialist perspective, particularly the BH provider perspective, and then the MassHealth member perspective. So this is how primary care exclusivity plays out. And just as a reminder, it's primary care exclusivity. So this is where there's the most change in the healthcare system. So again, today, a primary care provider can serve the members of the PCC plan and all 6 MCOs. That is not necessarily the case anymore. So if a primary care clinician joins an ACO, that changes their options. So working our way across the slide, as a primary care clinician, my ACO participation options are, so I don't participate in an ACO, but I still want to see MassHealth managed care members. Who can I serve? So if I want to continue to see MassHealth managed care members, I need to contract with the PCC plan and or the 2 MCOs, so Tufts Health Together and BMC HealthNet. in order to have any MassHealth managed care members on my panel. But what this means is I can't serve ACO members as a primary care provider. So I will not be able to see, so if I'm one of these types of docs, I won't be able to see Community Alliance members. I'm not going to be able to see WellForce members because I haven't joined those particular ACOs. So then moving down the slide, I'm a primary care doc. I've joined an accountable care partnership plan. So this is the Model A, the integrated ACO MCO. So who am I seeing for primary care? Well, I'm only seeing MassHealth managed care members who are enrolled in my ACO. So I can no longer see the MassHealth managed care members who are in the PCC plan, who are in an MCO. So I can't see BMC HealthNet or Tufts Health Together members anymore, or the members of another ACO. I'm limited to seeing the members who are enrolled in my ACO. Similarly, if I've joined a primary care ACO, so one of those statewide entities that is contracting directly with MassHealth and there's no managed care organization involved, I still can only see MassHealth members who are enrolled in my ACO. I can't have a primary care panel in any other MassHealth managed care product. So I can no longer see PCC plan members, I can no longer see MCO members, and I can't see the members of another ACO. And then just finally, because it's a little bit different for the MCO administered ACO, so this is Leahy Clinical Performance Network. So Leahy is required to contract with BMC, HealthNet, and Tufts Health Together. I have to contract with those two MCOs. And all of the MCO members who are assigned to my panel are going to be considered part of my ACO. But other than that, I can't have a primary care panel in any other MassHealth managed care product. So I can't see PCC plan members or ACO members. So then just moving on, so that's the primary care provider. This is the non-PCP perspective. So the general takeaway of this when we originally displayed it, and we still want you to take away, is that as a behavioral health provider, you can be in network, you can see all MassHealth managed care members, provided you are contracted to be in the appropriate network. There's no exclusivity that applies to you, and you're really hopefully dealing, not hopefully, you will be dealing with only 3 entities. So the dark orange bar, so this is non-residential recovery behavioral health provider, because it's a little bit funky at first for residential recovery. So if you're a non-RRS BH provider, if you want to see PCC plan and primary care ACO members, all you need to do is be in the MBHP network. You need to be in network with MBHP, and you can see PCC plan and primary care ACO members. Moving towards the center of the slide, your BH provider, if you want to see MCO members, just like today, you need to have a contract with Tufts, and you need to have a contract with Beacon Health Options to see BMC HealthNet members. But you can contract with both entities and you can see their members. And then finally on the far right, if you want to see accountable care partnership plan members, so remember there's 13 of them, you're going to need to, going back to that chart, you're going to have contracts with Tufts for those that are affiliated, for the 4 ACOs that are affiliated with Tufts. You're going to need to have the contract with MBHP to see Be Healthy partnership members. And then you're going to need to have a contract with Beacon to see the members of those 8 ACOs that utilize Beacon Health Options as their managed behavioral health benefit manager. But the gist of it is you are contracted with 3 entities and you can see all MassHealth managed care members. So that's sort of your sort of typical behavioral health provider scenario. Then going to the lower, the orange bar, this is really more about billing and how you get paid, but we figured we'd put it in here to hopefully clarify some things. So if you're an RRS provider, how are you getting paid for delivering services to PCC plan and primary care ACO members? So starting March 1st, you have to be in network for MBHP. You are billing MBHP for clinical services, and you're billing BSAS for room and board for the MassHealth members who have those plan types. So the PCC plan and the 3 primary care ACOs. And we have some slides that make this hopefully clearer later on. So then moving towards the MCOs and the accountable care partnership plans. So for those plan types, as of March 1st, you're going to continue to bill BSAS for both clinical and room and board services. So for the rest of this calendar year, you're billing BSAS for those plan members. Starting estimated January 1st of 2019, you're going to need to organize yourself like behavioral health providers do for services generally. So you're going to have to be in network for Tufts Health Together and Beacon Health Options for BMC HealthNet members to deliver services to those plans members. And then for accountable care partnership plans, you are similarly going to need to partner with Tufts, with Beacon, and with MBHP to deliver services to those plan members. So a little bit different for RS providers for this first year. And then just from the MassHealth member perspective, just walking through this. So there may be some instances, it's probably less likely on the behavioral health side, where MassHealth members are going to have to prioritize a relationship. So just like in the commercial space, MassHealth members are going to have to check their networks to make sure that the providers that are important to them are in network for the plans that they're getting assigned to. So if I'm a MassHealth member and I've followed my doc into an accountable care partnership plan, I can see that doc. So looking in the light green, I can see my primary care doc or any other primary care doc that's affiliated with that plan. In terms of, say I have a therapist or an OTP that's very important to me, for a behavioral health specialist, I just need to make sure that that provider is in the partnership plans network, or if they're one of the plans that use Beacon or MBHP, I need to make sure that they're in those networks. So I am going to have to do a little bit of homework to make sure that all of the specialists that are important to me are in network. And all of this applies equally to medical specialists, to pharmacies, and to hospitals as well. So, okay, oops, I've made a mistake. When can I change plans? Well, you can only change your plan during your plan selection period once a year. So we'll cover that a little bit later, but basically starting June 1st, MassHealth members are going to get locked into their plan choices for 9 months. So, you know, people are going to have to do some homework about the relationships that matter most to them. And then on the far right side of the slide, this is just to reinforce the dates, really. So if I'm a MassHealth member that needs RS services, so as of March 1st, you know, the provider needs to be a BSAS contracted provider in order for the provider to get paid. Starting January of next year, that provider needs to be in the Accountable Care Partnerships network, or if they're using an MBHO, it needs to be a network. So it's going to operate just like any other behavioral health specialty. Moving down, the primary care ACOs, so these are the 3 statewide ones. There's no managed care organization involved. So I followed my doc into one of those plans, so I can see my doc, or I can see any other primary care provider that's affiliated with that ACO. In terms of the behavioral health specialist that's very important to me, I need to make sure that specialist is in the MBHP network. And same thing, I've made a mistake. When can I change my plan? Well, unless I've moved out of the area or meet some other regulatory exceptions, I can only change my plan during the plan selection period, which occurs once a year. So for folks that are enrolled in primary care ACOs and need RS services, the RS provider needs to be in the MBHP network in order for that provider to get paid. Then moving down to the MCOs and the MCO-administered ACO, so it works the same way whether you're in Tufts and BMC or you're also a Leahy member. So I followed my doc, say, for example, to Leahy, so I can see any PCP in my MCO's network. And then in terms of behavioral health specialists, I just need to make sure that that specialist is in the network for the MCO. So they either need to be in Tufts if I'm in Tufts, or they need to be in Beacon if I'm a BMC HealthNet member. So same thing, when can I change plans? Only during my plan selection period once a year. So say I'm a Tufts member that needs RRS level of care right now. So as of March 1st, the provider just needs to be BSAS contracted. As of March 1st next year, the RRS provider is going to need to be in the Tufts network because I'm a Tufts member. But if I'm in BMC next year, they'll need to be in the Beacon network. And then finally, for the Primary Care Clinician Plan, I can see my doc. So I won't actually have been moved into this plan, but if I've chosen Primary Care Clinician, I can see that doc or any other PCC in the PCC Plan network. And then in terms of the behavioral health specialist that's important to me, I just need to make sure that they're in the MBHP network. And when can I change plans? Because MassHealth wants to encourage its members to enroll in more managed options, you can leave the PCC plan at any time. And then finally, I'm a PCC plan member and I need RS level of care. So effective March 1st, that my RS provider needs to be in the MBHP network in order for that provider to get paid for care delivered to me. So I know that was a lot to take in, so we'll stop for some questions.
All right, and we have received a good amount of questions, so we're going to take up to 5 minutes and try to get through as many of these as we can. If we don't address your question in this break, we'll be sure to try to get to it at the end.
Okay, so the first question is, we were told if we have contract with three entities, we would be okay, but that's not the case for my organization. Tufts, we are only contracted for 3 out of 6. How can we get contract information in writing? I've called and the story changes every time. Please advise. So I guess the first thing is look at your contract language. So my understanding is that because we haven't seen the contract language, it says something to the effect of MassHealth or Medicaid products. So I would start there. Second of all, if you can't get a straight answer, you can contact me and we can try to get an answer for you. There are certain instances where your contract might specifically list out the specific plan. So it may be the case that your specific contract says only 3 out of the 6, but that would be individual to your organization. As a general rule, from what we've heard from Tufts, is that it will just cover Medicaid products, so you will be in network with them. And they have reinforced this with us multiple times. Okay, so the next question, have MCOs indicated how they're going to handle all of the new authorizations for their members, especially for CBHI services? So the general requirement is that there's a 30-day continuity of care. Authorizations essentially will be honored for individuals during the 30-day transition. How that actually works out in practice, we really don't have we have no detail on that. So I think the question here is sort of how will you generate an auth and and if you had 12 units of something outstanding on February 28th, does that carry over past March 1st? There's really not a whole lot of answers from the plans on that, unfortunately. Would it be possible to obtain the list of names, telephone numbers, and extensions of individuals and all entities responsible for contracting? We don't have that information. Next question. As of March 1st for BH outpatient, if a member is in an ACO, is a referral required from the ACO PCP before the member can receive services? For outpatient behavioral health, the answer is supposed to be no. So if you are seeing that there's a referral requirement, we would want to know that. How are members supposed to make decisions before March 1st? It seems like many medical specialists and pharmacies don't know yet which plan they're part of when asked. I think that's an unfortunate reality. So that will probably lead to a fair amount of plan switching after March 1st. And if you sat through our last webinar, you could see it's really not very easy to navigate the different websites to figure out which providers are in which plans. It's relatively cumbersome, and I think your point is also getting at sometimes MassHealth members are even calling practices, and the practice isn't aware of which plans they're in. How do we look up which behavioral health providers are contracted with the ACOs? So this one, you would go to each ACO's website, and then usually there's some kind of link to the behavioral health network, so you would have to look them up that way. We were sending out, actually I believe it's attached to the webinar, there's links to some new MassHealth guides that sort of help you navigate the different websites. I would start with the links there. If you have questions sort of after this, we can answer that for you. But our new resource guide has new links about some desk guides that MassHealth has developed that are supposed to help you with that.
All right, so we got through all the questions, so we'll keep going.
Okay, so MassHealth Managed Care Member Communication. So we're going to do the next few slides fairly quickly. We went into these in depth in our second webinar, and we would encourage you to go listen to that or look at the slides for that if you want additional detail. So MassHealth has been envisioning its communication strategy as a series of phases. So there was initially awareness, we're now in operations, and then after March 1st, there'll be an implementation strategy. In terms of MassHealth member communication and the assignment timeline, so MassHealth noticed their entire managed care caseload in November and December, so all of the letters went out by about Christmas time. So about 1.1 million individuals received letters. They've been having MassHealth member enrollment events. They've actually just extended a few now into May. So the updated resource guide that we've attached has the new dates or has a link to the new dates for those events. MassHealth members, as of March 1st, though, MassHealth members become assigned to plans. So this is when they officially become ACO and MCO members, and that's when MassHealth members' plan selection period begins. So they become ACO and MCO members, but starting March 1st, they have until the end of May to change their plans, and they can change their plans as many times as they feel like. So it's not until June 1st that MassHealth members, what MassHealth calls their fixed enrollment period, begins. That means their plan lock-in. So that's when MassHealth members get locked into their plan choice for 9 months. And again, this doesn't apply to the PCC plan because you can switch out of that plan at any time. So MassHealth, they developed, again, they've sent notices to all of their members till about Christmas time. There's 5 different types, and there's a notice key that providers can use to help members understand their default enrollment. All MassHealth heads of household should have received an enrollment guide, which is also available online and on our website. MassHealth is sponsoring the enrollment events that I just referenced, so they've just announced a few more in May. There's a dedicated website to assist members in plan comparison and selection. It's called MassHealthChoices.com. And as we alluded to, it is a little bit cumbersome in that the website doesn't include behavioral health providers or other specialists. You kind of have to do some hunting and pecking to figure out who's available in each plan. All of these print materials are available on our website in the members only section under the MassHealth Systems Transformation page. And then in terms of provider communications, so MassHealth has done, they did a series of overview webinars, and now they're doing some operations webinars. The webinars that are ongoing right now, they include an overview of payment and care delivery innovation, so systems transformation, some sort of general information about continuity of care, health plan contact information, changes to the eligibility verification system that will help support this transition, administrative and operational functionalities, and then an overview of some of that member information and member tools. So those occur every Tuesday and Thursday. You have to register through MassHealth's learning management system. The link is right there. If you're not already registered with them, you'll have to create a login, and you will have to know your provider identifier site location number. So if you don't know what that is, my understanding is you can call MassHealth Customer Service Center and get it. And they've also, information about these is in the provider education handout, which is an attachment to this webinar. MassHealth has also been doing a series of in-person sessions, so there were a bunch in January that just concluded, and there'll be some more in March. Registration is required. The flyer that I just referenced has information about it, and you have to register, again, through the learning management system. MassHealth has a payment and care delivery innovation site for providers landing page, which has some helpful information on it. The link is right there. Off of that landing page, you can also find some provider-oriented fact sheets, some bulletins, information about webinars, and other information. MassHealth has created some provider fact sheets, so there's a link to the behavioral health provider fact sheet. They've done one provider bulletin so far, an all-provider bulletin. The link is off of that page as well. That provider bulletin talks about the ACO transition, and there's also these things called MassHealth Care Training Forums, which are regional and quarterly. The information and materials are available at that link on the slide as well. And again, the slides are available for download. So those, you can download past meeting materials from that website, and you can sign up for future meetings there. So we're going to stop for questions for a minute. So the question is, when an authorization is required, who provides the auth, the ACO or the MCO? So it's the plan that is running all of this. So if the Accountable Care Partnership Plan, it's so for the case of those affiliated with Tufts, it's Tufts. For those that are affiliated with the other plans, it's either Beacon, or in the case of Be Healthy Partnership, it will be MBHP. For the primary care ACOs, that's going to remain MBHP, and for the MCO administered ACO, it's going to be either Tufts or it's going to be Beacon for BMC Health Net. Can we get the slides from this webinar emailed to us? Yes, we will do that, and they're also available for download from the download pane. Okay, so we'll move on. So now what you've probably been waiting for, the SUD service expansion of MassHealth Systems Transformation. So Massachusetts received federal approval to offer a series of services as covered benefits for certain MassHealth members. So there's the American Society of Addiction Medicine, ASAM, level 3.1 level of care. So residential recovery services and transitional support services will meet the criteria for level 3.1. Massachusetts will be designing and procuring ASAM level 3.3 level of care. Recovery support navigators are going to become a covered benefit, and recovery coaches. The Commonwealth is also committed to a reinvestment in SUD services. So by expanding the MassHealth benefit to include services that are currently funded only by BSAS, like residential recovery services, we're going to capture federal matching funds, and those federal matching funds are going to be reinvested to fund recovery coaches, recovery support navigators, an ASAM-based assessment tool, and will allow for the creation of 500 new beds. So ASAM 3.1 services are a covered benefit for certain MassHealth members, for fee-for-service members, ACO, MCO, and PCC Plan members. There's going to be a phased service transition to managed care. So RRS clinical services, the billing and service management, are the lucky folks that are going to transition to managed care first, starting March 1st, with TSS following at a later date. So this is a kind of a busy slide, so I'll go through it slowly. So the transition to managed care for RRS. So starting March 1st, most Massachusetts Behavioral Health Partnership members are going to see that benefit managed through MBHP. So the clinical component for most MBHP members is going to transition to MBHP starting March 1st. So it's for members who are in the PCC plan and in the 3 primary care ACOs. So Community Care Cooperative, Partners Healthcare Choice, and Steward Health Choice. So RRS providers are going to need to register members of these plans with MBHP and then bill MBHP for clinical services delivered to members of those 4 plans. So then just as a note, because everything has to be confusing, services that are delivered to MassHealth members that belong to the Be Healthy Partnership should not be registered with or billed to MBHP at this time. So MBHP administers the behavioral health benefit for the Be Healthy Partnership. That's an accountable care partnership plan. That's not coming online until next year. The room and board component for PCC Plan and the 3 primary care ACO for services delivered to those members are going to continue to be billed to BSAS even after March 1st. In terms of the later transition, so non-MBHP members, so Accountable Care Partnership Plan members and MCO members, and MBHP Be Healthy Partnership Plan members, that's coming online in January of 2019. So the clinical component for all of these other folks will not be billed to those entities until January of 2019. So you will continue to bill BSAS for both the clinical and the room and board for their members. And then we understand that the clinical and room and board components for MassHealth fee-for-service members are going to continue to be billed to DPH BSAS for the foreseeable future. And then there will be no change for MassHealth managed care members or MassHealth members who are enrolled in senior care options, one care or program of all-inclusive care for the elderly. So they're not going to be impacted at all. That's not a managed care mandatory population, but some providers sort of have that in their head as managed care. That's not impacted by this transition at all. So this is what billing is going to look like March 1st. So hopefully you've participated in some of the MBHP, either the webinars or the in-person sessions, and this shouldn't be news to you, hopefully. So if the MassHealth member belongs to any of the following managed care health plans, so if they are a PCC plan member, or a member of one of the 3 primary care ACOs, so Community Care Cooperative, Partners, or Steward, you're going to bill MBHP for the clinical services, and you're going to bill BSAS for room and board. If the MassHealth member belongs to any other managed care plan, so another ACO or MCO, if they belong to a MassHealth integrated care option like SCO or OneCare, if they are MassHealth fee-for-service, or if they're uninsured, you will bill BSAS for clinical services and for room and board like you do today. So then just some additional details. Hopefully, again, if you participated in some of the MBHP training opportunities, this shouldn't be a surprise to you. So if you're not currently contracted with MBHP, you have to contract with them and complete other paperwork so that you can make sure you can access Provider Connect, which is their web portal. So that's where you'll be submitting claims and service requests. If you are currently contracted with them, you have a different set of paperwork to make sure you have the correct permissions and configurations. Starting March 1st, RRS providers are going to need to, first of all, continue to ensure that individuals who are in their programs meet the clinical criteria for ASAM 3.1 level of care, and you will need to check the MassHealth members' eligibility every day through MassHealth's eligibility verification system, which is called EVS, and it's accessed through the Provider Online Service Center, sometimes called POS, which is a web-based portal. Also effective March 1st, if you're an RRS provider, you'll need to register each individual through Provider Connect to initiate the first 90 days of service, and it's like a fresh start. So even if they've been in your program for 30 days, you get 90 days. For members who are PCC Plan members, and again, for any of the primary care ACOs, community care cooperative, partners, or stewards, so members of those 4 plans. And then just a note, a reminder that MBHP helps manage behavioral health services for the Be Healthy Partnership, and billing to MBHP is not going to happen for those members until 2019. So it's not going to be enough for you to look in EVS and just see that it's MBHP, because one of the MBHP plans isn't part of this. You're going to need to look to make sure the plan is one of those 4 bulleted plans above. So some of these are reminders, but also effective March 1st, RS providers, you'll be billing MBHP for clinical delivered to the members of those 4 plans through Provider Connect. Room and board still being billed to BSAS. If an individual in your program needs days beyond 90 days, you're going to request additional days through Provider Connect. So there's no limit on the number of days that you can request. You should be requesting the number of days that you reasonably anticipate for the individual to meet their treatment plan goals. And even after if you got additional time, if that individual still needs more time, you can make additional requests. As a provider, you're going to have to comply with the MBHP service specs. Those are based on the BSAS RFRs. MBHP is outreach to providers through webinars, regional meetings. They came to our residential committee recently. And if you have any questions on this, we strongly encourage you to contact MBHP. Their contact info is there. So one is sort of their general questions, and then if you have technical questions relating to Provider Connect, there's a separate point of contact there. And then just in terms of additional details about this transition, so percent of purchase, so the 80% bed purchase limitation has been eliminated by this transition to managed care. The 90 days, there's a lot of confusion about whether this is a treatment limitation. It's a starting point. So if they're clinically necessary, services will be authorized for additional days. Days spent in other levels of care aren't deducted from the 90 days that a person gets. If a person leaves RRS but returns, the provider might be able to use an existing registration if their end date hasn't elapsed. So you should see MBHP for more details about that, but you may not need to request another registration. In terms of offsets, so we had a question about that earlier. So you should subtract offsets like SNAP or whatever that you collect from the room and board that's billed to BSAS. In terms of clinical necessity, so the need for this service is based on ASAM 3.1 criteria. There's no limit on the number of times an individual can use RRS services. You should note, though, same-day billing for multiple 24-hour levels of care is not allowable under CMS rules. So, for example, a provider can't bill MBHP for clinical services while an individual is temporarily in an ATS. And so we understand that is a deviation from current practice under BSAS. If MBHP denies additional days due to clinical necessity, the decision can be appealed. If MBHP does deny your additional days, BSAS is not going to cover either the clinical or the room and board components of the service. And we are ABH is planning a training for members on ASAM 3.1 criteria for the near future. Then just more additional details. So the bed hold policy, we were at a meeting recently. This area definitely is awaiting additional clarification. The subspecialty performance specifications, I'm looking at Connie, did those come out?
No, not yet.
Okay. So the performance specifications for the subspecialties, like for young adults and pregnant postpartum, are scheduled to be made available this week. MBHP has also informed providers they're going to be changing their billing codes to align with the current codes used by BSAS. So they're going to be sending out contract amendments to reflect the new codes, and also anticipated that those will go out to providers this week. MassHealth, BSAS, and MBHP are developing a billing decision tree to help residential providers, which will be available soon. And MBHP is also developing an FAQ document that will address many of these same types of questions, and they anticipate that will also be available to providers this week. In terms of the expansion on the additional beds, so the federal matching funds, as we stated earlier, are going to be used to purchase new residential beds. The intent is to purchase beds with enhanced clinical capability to serve individuals with SUD and mental health diagnoses. There's going to be a letter of intent process for this, and it's expected soon. The Commonwealth has been very clear. Providers aren't going to be permitted to supplant existing beds. They're going to have to be new beds. And the Commonwealth has acknowledged there'll be some challenges around that. Commonwealth is also planning some new ASAM level 3.3 beds. So this is it will be new to Massachusetts, or at least new to the Massachusetts Medicaid program. So it's a specialized level of care with it's geared towards individuals where they have an SUD diagnosis, but also significant cognitive impairment. So BSAS and MassHealth are developing performance specs for those services, and they're expected for 2018. So more details on that will be coming. Recovery coaches and recovery support navigators. So these are going to be a covered benefit for certain MassHealth members. So ACO, MCO, and PCC Plan members will have access to recovery coaches and recovery support navigators. The anticipated launch of these is March of this year. Recovery support navigators will become available to fee-for-service MassHealth members, likely sometime in 2018. And recovery coaches may become available to the fee-for-service population at some future date. The Commonwealth doesn't have the authority for that right now. So BSAS, MassHealth, and the MassHealth health plans are developing the performance specifications for these services right now. And then just in terms of different resources that are available, particularly to RRS providers. So we know for some of you, checking EVS is a new thing. So first of all, if you didn't have EVS access by completing MBHP paperwork, that got you EVS access, we would encourage you to contact MBHP if you didn't receive anything about your EVS access. I don't believe it came from MBHP, but they're able to check on that for you. You check eligibility through POSC, so there's a link right there, and there is a MassHealth EVS desk guide, and the link is right there in the presentation as well. The MBHP website, so it's masspartnership.com, also has some information. So their webinar is available on it. They have contact info. They have regional network guides that talk about other services that would be available to MBHP members that you might want to take a look at, and they have contact information in that. Those are available online. The performance specs and the updated benefit service grid reflecting residential recovery services will be available after March 1st once this goes live, but they'll be available on the MBHP website. And the benefit service grid is quite handy in terms of billing codes and modifiers that may be relevant, and it also, you could just sort of see a list of all of the covered benefits that MBHP offers, and it's sort of eye-opening the breadth of services that are available to members. Then ASAM level of care, ASAM criteria information. So you can get information about ASAM criteria, and you can also purchase materials from ASAM off of their website right there. There is BSAS-funded online training through AdCare. The link is also in the presentation, and ABH is intending to offer ASAM training to members in the near future. So now we'll stop for some questions.
Okay, and we'll take about 5 minutes for questions. And just a reminder, as we're waiting for questions to come in, so this is the third webinar that we've offered, and we do have our past webinars available on our website. One provides a more in-depth overview of MassHealth Systems Transformation if you're looking for more, and the other provides more information on how you can help MassHealth members. But you will need a member login to our website, which we will be sending out instructions for how to sign up if you haven't done so already in the follow-up email.
So the first question is, what is the timing for TSS for MBHP members? When do we start billing MBHP for TSS?
I think it'll be 2019 before we get there.
Okay, so our phones don't go down that far. So the response from Connie was probably not until 2019. The next question is, I have yet to get a contract from MBHP for residential services. Do you know what the MBHP clinical rate is? So we actually got a list of providers that haven't done contracts yet, and you're not on it. Can you follow up with me offline, and we'll figure that out for you. Next question is, will there be training on how to go into the system to check if a client has MBHP for insurance? If so, when will this training be available to providers? So we've raised this with MassHealth originally. So I believe, Doris, you're talking about EVS. So we can circle back with MassHealth about whether they'd be willing to do sort of like an EVS 101. Let's see. Can we bill BSAS for room and board while the member is in ATS, project respect, et cetera? So this needs some clarification, but our understanding is the intent is that BSAS may cover it, but that needs to be clarified. You definitely cannot bill MBHP for it. Let's see, the next question is, can we expect some literature from MCOs regarding recovery coaching and rates, contract amendments? Yes, they're developing the performance specifications right now, so that would certainly follow thereafter. Yeah, it will certainly not be until after March 1st. What are the credential requirements for recovery coaches and navigators? We don't know yet. We haven't seen any of that. Let's see. Do we know anything about the reprocurement of BSAS supportive case management? The contract's for only 1 year.
I think we're still waiting to hear from both BSAS, DPH, and then as well EOHHS and MassHealth around what their plans are. But that BSAS has committed to keep those contracts funded until it's all resolved.
Were you able to hear Connie's response to that, Ellen? Okay, so then let's see. If MBHP denies additional days, can you clarify the payer of last resort policy as you understand it? Essentially, a non-MBHP MassHealth member could stay for an entire length of stay, which could be 6 to 9 months, but an MBHP member is dependent on an authorization. Your understanding is correct. So our understanding is that the BSAS payer of last resort policy will not cover an individual if it is determined that the service is not clinically necessary. They will not cover the clinical component, and they will not cover the room and board component.
All right, looks like that's all the questions. So we're going to continue.
So this is our last slide. So this is just the time frame for all the systems transformation. So we won't recap the past information. We will note that there are applications for statewide investments, which will include things like loan forgiveness and other workforce items will be happening no earlier than March. So we'll get information out to our members when that happens. MassHealth has been having the information sessions for members. Those will go through May. The healthcare training forums that we linked to earlier, those will continue to happen. So again, March 1st, all of this goes live in terms of MCO and ACO enrollments. The RRS expansion to PCC Plan and Primary Care ACO members, that also goes live March 1st. MassHealth members get locked into their plan, so their fixed enrollment periods begin on June 1st. And then community partner member onboarding happens in June, and we will do a webinar on community partners as that gets closer. So thank you very much.
All right, so we're going to give everyone one last opportunity to submit any additional questions. While we're waiting for those to come in, just a reminder, we'll be sending out an email following the webinar, both with a survey for you to provide feedback on the webinar and also with the slides and handouts for your reference. And then once the webinar recording becomes available, we'll send out an email letting you know that it's up on our website.
So we have one more question. Is the meeting on Monday about this information? So I'm not sure which meeting. If you're talking about the ABH billing committee meeting, we will cover the RRS stuff for sure. I'm not sure if you're talking about another meeting. I don't see. Okay, great. All right, so then the next question is, if we have a client that comes up with Steward Health Choice, I am understanding that we would bill this through MBHP. Correct.
All right, we'll stay on for a couple more minutes in case anyone else is sending in any questions, but for anyone who needs to jump off, I want to go ahead and thank you for joining us, and feel free to follow up with any of the ABH staff if you have additional questions that come up.
The contracts from MHP are confusing because they include room and board codes. Do you know why they are listed if they are not paying the room and board?
They're supposed to be receiving new contract amendments this week. I hope that clarifies the situation.
So just to repeat what Connie said in case you couldn't hear it, your new contract amendments that are going to reflect actually different codes as well, we are hoping will clarify that. But yes, we can understand why that's confusing.
But please call ABH if they get their new contracts and they just still can't figure it out.
When you run insurances for BMC, how will you know if a patient is ACO or MCO on the screen? So if you, on the ABH website, on the members only section, there's a section that talks about EVS enhancements that actually has screen prints that can show you what the eligibility verification system is going to look like and how you would distinguish that. If you are not able to find that, you can email me, Lydia Conley, LCONLEY @abhmass.org, and I can send you those screenshots so you can see what they're going to look like. And actually, you know what, we'll just send out the EV screenshots after the webinar.
Okay, it looks like that is all the questions we have. I think we've sufficiently provided you with information overload, so we're going to go ahead and say thank you and hope to see you on our next webinar.